Thank you for inviting me to talk about corneal aspects of congenital aniridia. Aniridia is a panocular congenital eye malformation, its name only describing the most obvious clinical manifestation. Various aniridia-related complications threaten the patient's vision and may lead to blindness. Diagnosis is usually made in early childhood. Moderate and atypical cases may present a diagnostic challenge to the clinician. There are still no straightforward, generally accepted treatment modalities. In the last 2 decades, the preferred treatment options have changed considerably. The cause of aniridia-associated keratopathy lies in the limbal stem cell insufficiency. In healthy eyes, the limbal stem cells support the regeneration of corneal epithelium. Insufficient regeneration of corneal epithelium leads to opacities and scarring, as is the case for aniridia. The onset is often already in the first decade of life, even if clinically no symptoms are present yet. Early stages can be visualized with fluorescein angiography before they become symptomatic as corneal opacities. So far we know that cyclodestructive interventions, air condition, eye drops with preservatives and antiglocomatous eye drops are risk factors for progression of aniridia-associated keratopathy, while the role of contact lenses is still not yet finally clarified. Aniridia-associated keratopathy usually manifests in the first decade of life. It can be described as a progressing conjunctivalization of the cornea and increases the risk for any kind of surgical intervention. Non-surgical treatment of aniridia-associated keratopathy include dark glasses against photophobia, preservative-free and phosphate-free lubricants, hyaluronic acid containing artificial tears, evotears, dexapantanol ointment at night, autologous serum eye drops. In case of vascularization and inflammation, unpreserved and phosphate-free steroid eye drops and scleral contact lenses might be used. Surgical treatment options include repeated amniotic membrane transplantation for non-healing erosions, while the panectomy with excimer PTK can address superficial corneal opacities. As an example, here are the images of a patient before and after PTK. The main goal is to stabilize epithelial adhesion rather than to achieve a crystal clear cornea. As Saint-Marie and Corsa showed, the density of hemidesmosomes significantly increases after PTK and therefore the epithelium becomes more stable. In highly selected adult patients, penetrating keratoplasty may be a valid option to gain some years of improved visual acuity. In the following, a few examples before and after keratoplasty. This patient presented with dense vascularized stromal scars and dense brown cataract. She was considered bilaterally blind for almost 30 years. Her visual acuity increased to 0.16 after surgery. Also, keratoplasty could achieve an improvement for some time. Due to repeat erosion and inflammation, graft survival is significantly reduced compared to keratoplasty in healthy eyes. In an attempt to optimize the outcome of this high-risk procedure, we found that best results were achieved using systemic immunosuppression, simultaneous amniotic membrane patch, temporary lateral tasography, autologous serum eye drops, and a 17 mm therapeutic contact lens. To summarize, treatment options include artificial tears containing hyaluronic acid, semifluorinated alkanes, dexapantanol, autologous serum, and scleral contact lenses. Penetrating keratoplasty should be performed with systemic immune suppression, multiple single sutures, simultaneous amniotic membrane transplantation as a patch, 17 mm therapeutic contact lens, lateral tassorrhaphy, and autologous serum. As usual, no corneal transplantation is performed in case of uncontrolled inocular pressure. I'd like to conclude by saying that effective treatment remains elusive. The pathology is still not sufficiently understood. There's a need for an aniridia register to be able to offer individualized approaches based on solid data. Thank you for your attention.
So thank you very much. Thank you for this effort in joining us, and indeed congratulations for it. The session is closed and we have lunch. Okay? Yeah.